Hi everybody, welcome to Coastal Quickies. I love the name. I think we got to give credit for that name to Dr. Cook. She decided that name was a good name and I love it. So I'm here with you guys today over lunchtime. Hopefully you guys are settling back and having a nice lunch. And I just introduced myself in Dr. John Schnorr. I'm an OB/GYN trained doctor who did a fellowship in reproductive endocrinology, which means that we're really the endocrinologist of the OB/GYN space is kind of where we are. My fellowship was at a place called the Jones Institute, which is in Norfolk, Virginia, which was famous for having the very first live birth from a gonadotropin stimulated IVF cycle, which is how it's done now. And really admire all the people who trained me along the years, and I'm grateful to be able to be here with you guys today to talk a lot about what's common in your mind. It likely is, how do you optimize natural fertility? Like if you're having a hard time getting pregnant, what can you do to make it better? Maybe eat more grapefruit or maybe eat more strawberries or whatever. I know all that stuff is out there on the internet, and part of my job is to debunk that, to show you that that's really not the answer and help get your focus on what really does matter along the way. So we got 10 to 15 minutes scheduled to do that. We have Holly who's here with us, which I'm grateful for. Holly's going to be looking for any questions you have. So interrupt me mid-sentence and mid-speech with a question to Holly. Holly will chime in and give me that question. I'll answer it in front of you guys. And at the end, we'll also pause to see if you have any questions that you want me to answer towards the end. So we're here today to talk about optimizing fertility, which means, what is the normal fertility rate? Are there things you can be doing to make things better? I think in high school, they kind of headed us in the wrong direction on this line of thinking. They wanted us to stay away from each other. They wanted us to abstain from intercourse in high school, which we still support. And they told us the pregnancy rate was 100% every time we try, so don't even try. And that's just stuck in our head. I was giving a lecture to medical students yesterday. Medical students being, really smart people who are driven and focused on the healthcare field. And we had probably 30 medical students with us yesterday when I was talking to them. And I asked a question. I said, what's the normal pregnancy rate for a 35-year-old couple having regular intercourse? And by normal, I mean there's no female problems, there's no male problems, they're having intercourse every other day. What is the pregnancy rate, right? Bunch of smart medical students. Somebody said 93%, somebody said 12%, another person said 56%. I don't know where they got that number from. But anyway, the answer is 20%. 20% chance of pregnancy if you're totally a fertile, healthy woman having intercourse with a fertile, healthy man. 20%. 1 out of 5 months you get pregnant at 35 years of age. Why is it that low? Well, it's that low because 56% of all ovulated eggs out of a 35-year-old woman are chromosomally abnormal. The vast majority of ovulated eggs are chromosomally abnormal. And the vast majority of resultant embryos are chromosomally abnormal. And an abnormal embryo won't grow in the uterus, or if it does grow, gives you a very high chance of miscarriage or even a baby with a birth defect. So, it's abnormalities of the egg primarily that lowers monthly pregnancy rates. As a woman gets older, as you might guess, that trend is not favorable. Pregnancy rates go down. At 40 years of age, totally healthy reproductive couple having regular intercourse, probably a 10 to 15% chance of pregnancy per month. 42 years of age, 5% chance of pregnancy per month. 44, 45 years of age, 1 to 2% chance of pregnancy per month. And so the question becomes, what's normal fertility, number one? Number two is, what can you do to optimize it or make it better? And so we think there are things you can do to make things better. There's an abundant amount of information about prenatal vitamins and how prenatal vitamins can lower the risk of what we call neurotube defects. These are birth defects that have to do kind of with the spinal cord and the brain development. It doesn't help you get pregnant to take birth control pills, but it lowers the risk of birth defects to take birth control pills. Now, the American way is more, and so therefore we would think maybe the more expensive birth control pill is the one to get. No, not really. You just need a birth control pill with folic acid in it that has 600 micrograms per day or more of folic acid. I would not be spending extra money to get special supplements in my birth control pill. It's all about folic acid. Otherwise, you're just making expensive urine to be spending a lot of money on expensive birth control pills. expensive prenatal vitamins, sorry. Don't be taking birth control pills while you're trying to get pregnant. That's the other message for today's talk. But don't be spending a lot of money on expensive prenatal vitamins. The second thing that I would be doing is there is some good data on exercise. The more you exercise, the better your fertility rate is. So I would be exercising. Part of that is getting blood flowing and circulating. It's healthy for your brain to be exercising, and it actually lowers body weight. That there is an abundant amount of literature out there that as female body weight goes up, pregnancy rates go down. Interestingly, as female body weight goes up, miscarriage risks go up. And that's found even with chromosomally normal embryos, which is a lot of the causes of miscarriage are chromosomally abnormal embryos, as I mentioned earlier, trying to grow into the uterus. Well, if you control for that and do genetic testing of the miscarriage, you find that women with a body mass index of greater than 30 more commonly miscarry a chromosomally normal embryo. And so there are a variety of different ways to measure weight, all right? Scale is one, right? How much do you weigh? But it's fair that if you're 6'3", you should actually be able to weigh more than if you're 5'3", right? And so body mass index calibrates for that. So that's a way you can go into Google and you say body mass index calculator, you put in your height, you put in your weight, it gives you your BMI. Most medical studies use BMI. Ideally, your BMI would be less than 30. It does not mean you can't get pregnant if you have a BMI of greater than 30. It just means you get pregnant at a lower rate, and it means you miscarry at a higher rate. I get patients a lot who come in on the heavier side of things, and honestly, they get a little bit mad when I bring it up, but it's the medical literature that it's my responsibility to go over with you. I'm not saying you got something you can't fix. You can fix it. I'm particularly impressed with the newer GLP-1 agonists and antagonists, which are Ozempic and Mounjaro and these other medicines. We don't prescribe those, but your endocrinologist can. They have a way of giving you an injection once a week that lowers your appetite and lowers your weight, and we think that's going to significantly improve outcomes. It used to be discussions of bariatric surgery, now it's some of these newer medicines. So weight reduction, exercise is going to be really important for optimizing fertility. The other thing that we want to do is make sure that you're eating a well-balanced diet and not overdoing it on things. There is no evidence that certain diets are going to improve fertility. We think a well-balanced diet and keeping your weight down and exercising, there's no belief or benefit that if you eat more grapefruit or if you eat more orange peels, or everybody's got their own little thing, but if you really think about it, what's unique about you that makes you need more grapefruit than your next door neighbor who's getting pregnant at a regular basis? What's that medical disorder? Well, there aren't any medical disorders that we know of. Next thing is optimizing your current health, right? If you've got asthma, then you're going to have a better pregnancy rate and better pregnancy to have your asthma well controlled. Diabetes, for sure, the lower your sugar levels are, the better your pregnancy rate is, the lower the birth defect rate is, the lower the miscarriage risk is. Whether it's type 1 or type 2, you want to get that under control. So you want your medical history kind of taken care of so you've optimized things. What about medications during pregnancy? Well, I would check with your doctor to make sure that you're on a safe medicine during the pregnancy, and we want you on the lowest effective dose. And that's an important one I'm going to come back to in a second, that, if 20 milligrams and 10 milligrams of a drug give you the same outcome, then you should be on 10 milligrams because you have less drug circulating and therefore less challenges with that drug circulating. A lot of questions about antidepressants and SSRIs and those types of things. The studies show that there does not appear to be an increased risk of birth defects with those. We want you on them if they're helping you, that we're concerned that if you have depression and anxiety before you get pregnant, that it could be worse after you deliver the baby or even during a pregnancy. And so if you need it, you need it. But going back to that last discussion, we want you on the lowest effective dose to do that. There are other things you can do to improve outcomes. We think taking the flu vaccine every year is a good idea. We think if you get influenza during pregnancy, you're going to have increased complications during pregnancy. And so again, trying to set forth for a healthy pregnancy would be good. And so getting the influenza vaccine. COVID vaccination is also supported by the CDC and the medical literature, so I think that's a reasonable thing to do. Rubella vaccination, varicella vaccination, that's chicken pox. All these things are important to do before you get pregnant to make sure that you're ready to get pregnant. Now, a lot of things that trip up Americans are not only weight, but also alcohol consumption. I think when we look back at history, we're going to find that alcohol at some level is a toxin, right? And I'm not saying I don't drink alcohol, I do so in moderation, and I'm not saying you shouldn't drink alcohol if you choose to do so, but moderation, what is moderation? For a woman trying to conceive, it's generally less than 4 glasses of alcohol per week. And so that would be a consideration for men due to kind of the hepatic function of men and what they call the P450 system. It seems like they get away with a little bit more alcohol consumption. So I would say for a man, again, we don't have great studies on this, but probably less than 10 a week, right? Now, if you're having problems of recurrent pregnancy loss, if you're having problems of male factor infertility, other things, I think there could be a very cognitive argument made to say just stop alcohol altogether, right? And so I think that would make sense. The other thing we talked about is tobacco use. This is a no-brainer. We clearly know that tobacco use is going to lower fertility rates, increase miscarriage risk, going to cause ovarian failure. It's going to lower sperm count rates. Another area to talk about is marijuana use. I think the United States in general, maybe even the world, is becoming a little bit more liberal with marijuana use. We know marijuana is very harmful to fertility. That's been well documented, that for people trying to get pregnant on the female side, marijuana use will lower pregnancy rates. Male factor infertility will lower pregnancy rates to take marijuana. If you look at a person's health, there are some recent publications showing that marijuana use decreases the amount of white matter in a person's brain. White matter is the thinking part of our brain, showing there may be long-term harm with marijuana use. There's worries and concerns that are valid that marijuana is kind of a scavenger when it grows, and it brings bad nutrients out of the soil, and it puts those bad nutrients into the marijuana leaves that you then inhale. What does that mean? Increases in lead, increases in cobalt, increases in other heavy metals are associated with that. And so we're now seeing that in people having adverse reactions to marijuana use because of that, and that's not something you can control for. I know you think maybe Schnorr's not on the right side of marijuana. Well, when the Chernobyl accident happened in Russia, they planted hemp, which is a form of marijuana, to try to get all the radioactive materials out of the ground, because that's what these plants use. And if you're then smoking it or using it, whether it's edible or smoke, you're ingesting this in your body, and our bodies can't get rid of the heavy metal that we put in our body. So we don't have a way of scavenging and getting that out. So enough of my soapbox on marijuana, but we see it a lot as reproductive endocrinologists where marijuana is complicating people's fertility. I'm not saying you can't get pregnant if you smoke marijuana. We just think you get pregnant at a lower rate and possibly have an increased miscarriage risk. Last but not least, caffeine. We all love caffeine at some level. We do think that caffeine in excess can be a problem. It's a challenge because not everybody's cup is the same size and not everybody's brew is the same concentration. But the general recommendation would be less than 200 milligrams of caffeine a day for somebody trying to conceive. That's 2 regular cups of coffee, each regular cup of coffee being about 100 milligrams. If I had miscarriage problems myself as a woman, I would cut out caffeine altogether, because if there's a link, it's going to be that link with miscarriages. That's going to be the most potent link. But I think cutting out caffeine, or at least minimizing caffeine, becomes another good thing to do. In regards to frequency of intercourse, again, in America, more is more, so we would think 3 times a day would be more. Reality is that probably would not be a positive. We think if you look at frequency of intercourse, sperm seems to live in the reproductive tract for several days, and so we would think intercourse every other day appears to give the same pregnancy rate as intercourse every day. And so as not to wear you out and you keep it fun and exciting, probably every other day, every third day would be recommended if you're trying to get pregnant. A lot of people love ovulation predictor kits that kind of show you when you're going to ovulate in advance. They're expensive, they're anxiety producing, and they're not always accurate. So imagine that your kit's inaccurate and your kit's telling you you're not ovulating when you really are ovulating, so you're not having intercourse, and therefore you're not getting pregnant because your kit's inaccurate. Rather, we think, forget the kits, throw them away, have intercourse every other day or every third day around that window of ovulation. People who have 28-day cycles generally ovulate around day 14 of their cycle, so I would say regular intercourse between day 10 and day 20 of the month. The rest of the time is just for fun, and just have intercourse every other day kind of during that time frame. If you're pilots and you're not together all the time, or there's other issues that you cannot have regular intercourse, then I think there's a role for ovulation predictor kits and optimizing fertility. For a woman to conceive, you shouldn't need any special hormonal supplementations unless there's something abnormal. If you've been trying now for, let's say, greater than 6 months or so and you've not conceived, and you probably should have, it's not wrong to start doing some investigation. This is a time when your OBGYN or a reproductive endocrinologist like myself can just start looking a little bit to see what might be going on. And ultrasound to make sure the uterus is structurally normal, to make sure you have a good number of eggs in your ovary becomes a good idea. Maybe do an x-ray to make sure the tubes are open and working. Certainly checking a sperm count. Sperm counts are ideally done with 3 days of abstinence. Coming in for testing doesn't mean you're committed to treatment. You're not. You're just finding a little bit more information to figure out if there's anything you need to be concerned about. If we find that the sperm count's low and you've been trying for 6 months, we might say, let's do some investigation to make that better. We're not saying don't continue to try. We're just saying let's try to give you a little bit more resources to make that work. So I'm going to stop there, see if you have any questions along the way. I think we do, and we'll see what we found out.
Yes, so Amber wants to know, do you recommend one specific fertility predictor kit or device?
Yeah, so the question was, do we recommend one specific fertility predictor kit or another? I don't have any data to say that any is better than the other. I personally think that your calendar is your best way of figuring that out. When you had menstruation, you're going to ovulate on average 14 days later when your period starts. By definition, we call your first day of menstrual flow day 1 of your cycle, and so around day 14 or so, but generally don't recommend ovulation predictor kits.
And Cindy would like to know, what would you recommend to help regulate very irregular cycles, 30 to 66 days?
Yeah, so the question is, what do we do to regulate irregular menstrual cycles? And what irregular menstrual cycles mean to me is irregular ovulation. And irregular ovulation can come from either your egg count being low or your female hormone levels being low. And that generally means you need an evaluation to figure out which one it is. And if you need hormone supplements, that's a very specific prescription that's going to be based upon what the underlying diagnosis is, age, weight, all that other kind of stuff along the way. So if you're having irregular cycles, that's a red flag, means you need to go to your OBGYN or reproductive endocrinologist to figure that out.
Okay, and then I have another question from Tess. Can you share information about AMH levels?
Right. So the question is, what about AMH levels? Now, AMH is a relatively new hormone on our screen. We've had it in our bodies the whole time. We in medicine just didn't know it was there. Probably discovered AMH maybe 10, 12 years ago. It does appear to be a very accurate predictor of egg count within your body. So you're born with all the eggs you're ever going to have. You gradually use those eggs up. AMH levels go down as a woman gets older. We're not all born with the same number of eggs. Therefore, 33 years of age, we don't all have the same number of eggs. And so AMH is a measure that can be done on any day, on any time of day. The assay is now fairly standardized and it's accurate. We like an AMH level that's greater than 2.5. Doesn't mean you can't get pregnant if your AMH is lower. A low AMH predicts a lower number of eggs. It just means you may have some fertility problems as a result. I would think an AMH which would be particularly concerning would be an AMH of less than 1.0.
I have several more comments.
And that's the end of the comments, is that right?
No, we have several more.
Oh, we have several
Yes,
more. Okay,
so
let's take them. We got it.
Carly would like to know, should we reach a year plus with all tests, scans, x-rays, etc. being perfect, do you recommend Clomid, IUI, or IVF next?
Great question. So this is a question really that we would say if you have unexplained infertility. Unexplained infertility means you've been trying for a year, you got a normal x-ray, blood work, sperm count, you're ovulating on your own. That's called unexplained infertility. We used to operate on every patient with unexplained infertility. And what we found when we did that surgery is that patients with unexplained infertility have a significant increased risk of pelvic adhesions, endometriosis, and other internal things causing their infertility. What we also learned from those same surgeries is that surgery did not improve outcomes, right? So if we operate on you and take a picture and do nothing, take a picture, move on, the outcome functionally was the same as if we cut away scar tissue and endometriosis, which means there's no sense in doing the surgery. So if you have unexplained infertility, we generally know that it's going to be adhesions and endometriosis as the high incidence. Surgery is not going to help you. Now, studies on Clomid show that Clomid help you ovulate if you don't ovulate, but what we just talked about is the fact that this is an unexplained infertile situation, which means you already ovulate, which means giving you an ovulation agent will actually lower your pregnancy rate, not increase your pregnancy rate. Where does that come from? We have multiple studies that now show that the administration of Clomid for a woman who already ovulates thins the inside of the uterus, decreases cervical mucus, and lowers pregnancy rates. A beautiful study in the United Kingdom, unexplained infertile couples on nothing had about a 17% chance of pregnancy over 6 months. With IUI alone, no medicines, had a 21% chance of pregnancy. And with Clomid, had a 14% chance of pregnancy. So if you heard that right, the pregnancy rate from 17% to 14% being on Clomid, our national society says if you have unexplained infertility and you're having regular periods, Clomid is not a benefit to you. IVF certainly is something we would consider. IVF will give very good pregnancy rates, bypassing endometriosis, adhesions, has many other benefits. Intrauterine insemination can be a benefit. I mentioned that insemination pregnancy rate from 17% to 21% in the study. So the mechanism of putting sperm in the uterus seems to improve pregnancy rates. We do use injectable medicines, not oral medicines, which also seem to improve the pregnancy rate. So the recommendation would be unexplained infertility, let's be seen, probably do either IUI or IVF. IVF will get you there quicker with a higher cost, but at the end of the day, as I said, it gets you there quicker.
Are there supplements or vitamins that you suggest?
Yeah, supplements or vitamins I suggest. You know, I get this all the time. You know, everybody's on 15 different supplements and vitamins, and then when I try to talk them off of that cliff, they say, no, it's natural. And I say, yeah, so is arsenic, right? Arsenic is a very natural substance that when concentrated kills you. Also recommend that men for many, many years thought that vitamin E lowered prostate cancer risk. There was some preliminary evidence that supported that. And so many men were on vitamin E to lower prostate cancer. The first prospective randomized clinical trial that came out showed an increased risk of prostate cancer for men who were on vitamin E. And so when you're on a, quote, natural substance, and you're concentrating it and putting it in your body at a higher concentration, there's a high chance you're going to do more harm than good. And so I think what we need for anything that we prescribe is safety first, efficacy second. If it's not safe, there's no reason to study to see if it's efficacious. If it is safe, we then study it to see if it's efficacious. What I reviewed with you is what the medical literature supports. I think prenatal vitamins, and there may be some evidence on vitamin D. Vitamin D does not appear to be harmful, may be beneficial. We live enough time indoors, using sunscreen and hats and all that kind of stuff, which I support. I support all that stuff. You probably would benefit from a little bit of vitamin D. I generally prescribe 5,000 units of vitamin D daily in addition to your prenatal vitamins. I don't think there's any evidence on any other supplements other than maybe, underline maybe, coenzyme Q10, which we think is the enzyme in eggs that makes energy within eggs. Maybe a benefit to take that if you're 37 years of age or above, but that's a maybe also.
Okay, Mika wants to know, how much does thyroid affect fertility?
How much what?
Does the thyroid affect?
Yeah, so it's another great question. Thyroid disease. If you're overtly hypothyroid, meaning your level is really high for your TSH and your T4, T3 really, really low, you need to be on treatment. It's healthy for you. If it's bad enough, it will disrupt your menstrual cycle. We think if you're having regular cycles with thyroid problems, it's probably not a problem. For those with subclinical hypothyroid, meaning their thyroid is just maybe slightly above what might be normal for a pregnant woman, that is not thought to be a cause of infertility, and so it's not going to be a problem. But it should be corrected. In general, we want a woman's TSH level, thyroid level, to be less than 2.5 when she's trying to become pregnant. If it's a little bit above that, we'll check your antibodies, we'll check your free T4. There's other things we can check to make sure that things are okay.
And I think that's it.
You guys are awesome. I hope you have a good lunch, and I appreciate you spending time with me. And if you ever need us, we're here at Coastal Fertility. We'd love to help you. Take care.